Hello class, it's me, Dr. Jenkins, and for this module we're going to be talking about acid-base disorders. These are our learning objectives for this module, so we're going to talk about the four most common acid-base disorders. We're going to develop a simplified approach to interpreting arterial blood gases. We're going to define and calculate the anion gap and then talk about different causes of elevated anion gap and normal anion gap metabolic acidosis. And we're going to look at the different ways that the body responds to acid-base disturbances with the lungs and the kidneys. All right, so we have a 30-year-old man who is found unresponsive and brought to the emergency department by EMS, and we have this arterial blood gas. And for all of these blood gases, I'm not including everything that you would see on a blood gas, which would also usually include the partial pressure of oxygen, since the focus of this module is really just on acid-base disturbances. So the first thing we see is the pH, which is 7.16. The partial pressure of carbon dioxide, so this is the carbon dioxide dissolved in plasma, is 80, and the bicarbonate level is 28. So how do we read an arterial blood gas? The first step is to look at the pH and decide, is this acidemia or alkalemia? And the next step is to look at the PCO2 and the bicarbonate to determine whether either of them could explain the pH. Then the next step is to look for appropriate compensation. And if you don't see appropriate compensation, then that could suggest that there's more than one acid-base disturbance going on. So let's cover some definitions. So acidemia is when the pH of blood is less than 7.36, and alkalemia is when the pH of blood is over 7.44. Now, if you have acidemia, then there must be an acidosis, and this is any process that causes an increase in your proton concentration. That's going to cause acidemia. Likewise, an alkalosis is a process that causes a decrease in proton concentration. There's a couple numbers that you should memorize. These are the normal values for PCO2 and serum bicarbonate. So normal PCO2 is 40 millimeters of mercury, and a normal serum bicarbonate is 24. All right, so back to this case then. The first step is to look at the pH, and our patient's pH is less than 7.35, so he has acidemia. So then the next step is to look for a metabolic or respiratory process. So we look at the PCO2, and it is elevated, and so the question is, does that explain the pH? Can an elevated PCO2 cause an acidemia? And yes, it can. So how does an elevated PCO2 cause acidosis? Well, you guys remember this, this equation of carbon dioxide plus water can become carbonic acid, and that reaction is catalyzed by carbonic anhydrase. And carbonic acid can dissociate into protons and bicarbonate. And so if you have a lot more CO2, that's going to drive a lot more production of carbonic acid, and so you're going to end up with more protons. So when it's caused by elevation in PCO2, we call it a respiratory acidosis. And so what causes that? The major causes are going to be hypoventilation, so slow and shallow breathing. And that can be caused by anything that depresses the central nervous system. So sedatives are a common cause of this, like opioids and benzodiazepines. Neuromuscular disorders can lead to hypoventilation, and that's usually going to be more of a chronic problem, but you can have acute exacerbations of these things. But things like spinal cord injuries, Guillain-Barré syndrome can all lead to hypoventilation. And then restrictive lung diseases can also cause hypoventilation because you have a lower tidal volume. Obstructive lung diseases are another common cause of respiratory acidosis, and so typically asthma is not going to cause respiratory acidosis unless it's a very severe exacerbation and they have impending respiratory failure. Whereas COPD, you often have a chronic respiratory acidosis, and then that can get worse if they have an exacerbation of their COPD. And then another cause of respiratory acidosis would be like an airway obstruction, like if you didn't chew your food very well during Thanksgiving and you were choking. If you block off your trachea, you will have a buildup in CO2 and respiratory acidosis. So how does the body respond to respiratory acidosis? Well, normally the brainstem will detect that drop in pH and rise in PCO2, and it will respond by increasing respiratory rate and tidal volume, so hyperventilation to get rid of that CO2. But in a respiratory acidosis, usually there's a problem with the lungs, and so that's where the kidneys will come in and they'll secrete those extra protons in the distal nephron and generate new bicarbonate, which will try to bring the pH closer to normal. So you'll remember in the type A intercalated cells of the distal nephron, they can secrete protons either through the hydrogen ATPase or the hydrogen potassium ATPase, and those protons come from carbonic acid. So the carbonic acid can dissociate into protons and bicarbonate, and the protons can be secreted by the ATPase into the filtrate, where the protons will then bind to ammonia to form ammonium, and that is excreted in the urine. The bicarbonate can then be reabsorbed into the interstitium through the anion exchanger with exchange for chloride, and that will increase the serum bicarbonate to try to return the pH to closer to normal. Now, this process of renal compensation takes about 3 to 5 days to kick in. And so in someone with a chronic respiratory acidosis, when they're able to generate that extra bicarb, you would expect the bicarbonate to increase by 0.4 milliequivalents or millimoles. We'll see that those are used interchangeably for each 1 millimeter mercury increase in PCO2. Whereas for acute respiratory acidosis, your acute compensation is going to be through the bicarbonate buffer system. And so you have red cells with bicarbonate in them, and that's generated from the same reaction with carbonic anhydrase and carbonic acid. Those bicarbonate ions can serve as a buffer, and so if you have acute respiratory acidosis, your bicarbonate will increase by 0.1 milliequivalent for each 1 millimeter of mercury that your PCO2 goes up. But you'll see that that is a smaller effect because you don't have as much ability to buffer as you will once the kidneys have generated new bicarbonate. So then if we look at our original patient here, we would expect, if this is an acute respiratory acidosis, that their bicarbonate will go up by 0.1 milliequivalents for each 1 millimeter of mercury increase in PCO2. And so if we take their current PCO2 of 80 and we subtract normal PCO2 of 40, we'll see that their carbon dioxide is 40 millimeters of mercury higher than expected. So we take that 40 millimeters of mercury and times it by that 0.1 milliequivalents of bicarbonate that you'd expect to see, and you'll see that you'd expect the bicarbonate to increase by 4 milliequivalents. And so if a normal bicarbonate is 24 and we add 4 milliequivalents, that would give us 28, which is what we do see in this case. So this does suggest that this is an acute respiratory acidosis. Now, if we have a 65-year-old lady coming into her pulmonologist with dyspnea and the following blood gas, we see the pH is 7.33, the PCO2 is 65, and the bicarbonate is 34. So we see the pH is less than 7.35, so we can say that this patient has acidemia. So then we have to ask ourselves, does the PCO2 explain the pH? And again, the PCO2 is higher than normal, so that does explain the pH. There is a respiratory acidosis present. So the next question is this acute or chronic? So we look and see that the PCO2 is 65. We subtract a normal PCO2 of 40, and we see that we're 25 millimeters of mercury higher than normal. And we times that by the expected rise in bicarbonate of 0.1 milliequivalents per 1 millimeter of mercury. And that gives us 2.5 milliequivalents. So you'd expect that the bicarbonate would go from 24 to 26.5 if this was acute. But we see that the bicarbonate is 34, so there must be something else going on. Remember, in chronic respiratory acidosis, when your kidneys have time to respond, you're going to increase your serum bicarbonate by 0.4 milliequivalents for each millimeter of mercury increase in PCO2. So if we take that 25 millimeters of mercury and we multiply it by 0.4, now we'd expect the bicarb to go up by 10. 24 plus 10 is 34, which is what we see in this case. So this suggests that this woman has a chronic respiratory acidosis. Now, when you're trying to decide if someone has an acute versus chronic respiratory acidosis, you can just do the math to figure it out, but you could also look at the pH, and if it's close to normal, then that suggests that this is probably more of a chronic process because the kidneys have had time to generate bicarbonate to get the pH closer to normal. Also, if you see that the bicarbonate is over 30, it's also probably a chronic process. All right, now we have a 30-year-old woman who's coming in to the emergency department with dyspnea, and her blood gas is shown below. So her pH is 7.48, PCO2 is 30, and the bicarbonate is 22. So since the pH is over 7.45, we'd say she has alkalemia. So that means there must be a respiratory or metabolic alkalosis causing that. So does the PCO2 explain the pH? So our PCO2 is lower than normal, so that could be a respiratory alkalosis, and that could explain this pH. So respiratory alkalosis will occur anytime that there is hyperventilation. So when you hyperventilate, which means taking deeper breaths and breathing faster, you're going to exhale more carbon dioxide, so your serum PCO2 is going to go down. And that decrease in PCO2 means you have less protons, so the pH will go up. So most of the causes of respiratory alkalosis are going to be lung diseases. So anything that makes you breathe faster, so like asthma, an asthma attack can make you breathe really fast, so you're going to hyperventilate and develop a respiratory alkalosis. Anything that causes hypoxemia is going to stimulate the ventilatory drive, and so things like a pulmonary embolism or pneumonia or congestive heart failure can all lead to an acute respiratory alkalosis. Also, a panic attack leads to hyperventilation, which can show up as an acute respiratory alkalosis. And then salicylate or aspirin intoxication actually stimulates the brainstem to breathe faster and could cause an acute alkalosis. You might also see this in sepsis, which can also lead to tachypnea. And then there's also chronic respiratory alkalosis, which is classically caused by pregnancy and cirrhosis. And it's thought that this is due to elevated levels of circulating progesterone, which stimulates the ventilatory drive. So how does the body respond to respiratory alkalosis? Well, for acute compensation, you can shift bicarbonate back into red cells in exchange for chloride. And so your bicarbonate will decrease by 0.2 milliequivalents for every 1 millimeter decrease in PCO2. And then for chronic compensation, again, this is a renal process, so the kidneys are going to stop secreting hydrogen protons and generating bicarbonate because the pH is high. And the bicarbonate will decrease by 0.4 milliequivalents for every 1 millimeter mercury decrease in PCO2. So if we have our 30-year-old lady with anxiety presenting to the ER with dyspnea, we say she has an acute respiratory alkalosis, so we can ask, is this acute or chronic? And so we would subtract her PCO2 of 30 from a normal PCO2, and we see that she is 10 below normal. And we would multiply that by the 0.2 millimoles of bicarbonate. You'd expect to see a difference, which would give you 2 millimoles of bicarbonate. So we'd expect her bicarbonate to go down by 2. And that is what we see. So this is consistent with an acute respiratory alkalosis. All right, now we have a 12-year-old boy being brought into the emergency department for lethargy, and his blood gas is shown below. So pH is 7.1. PCO2 is 16 and bicarbonate is 5. So the pH is less than 7.35, we can say there is an acidemia. So there must be a respiratory or metabolic acidosis causing this drop in pH. So first we look at the PCO2 and ask, can this explain the pH? So his PCO2 is lower than normal, and so that would be a respiratory alkalosis, so that does not explain the acidosis that we're seeing here. Then we look at the bicarbonate and say, can this explain the pH? And a low bicarbonate is consistent with a metabolic acidosis. So this person has a metabolic acidosis. So metabolic acidosis is defined as an increase in serum protons, and you would expect the serum bicarbonate to go down as it's buffering those additional acids. So how does the body respond to metabolic acidosis? Well, your brainstem is going to detect that drop in pH, and it's going to increase your ventilatory rate, so both your rate and your depth of breathing, to eliminate carbon dioxide. And by exhaling that carbon dioxide, you will be able to increase the pH closer to normal. So you'd expect the PCO2 to decrease by 1.2 millimeters of mercury for each 1 milliequivalent of bicarbonate below normal. And luckily, there's a formula for this. And that formula is called Winter's formula. And this is a formula that you should memorize because it's very helpful in figuring out if there is adequate compensation for metabolic acidosis. So the formula is your expected PCO2 is 1.5 times the bicarbonate plus 8. And then there's this plus or minus 2 to account for a margin of error. And so for our patient here who has a serum bicarbonate of 5, if we take that 1.5 times 5 and add 8, we're going to get 15.5. And that is pretty darn close to what the PCO2 is in this case. So this suggests that this patient has what you'd expect for their respiratory compensation. Now the next step in looking at metabolic acidosis is to evaluate the anion gap. So all bases are paired with cations and all acids are paired with anions. So you can think of anions as being footprints for acids in the blood. And if you have electrically neutral serum, then there should be equal numbers of cations and anions. But typically you're going to have more unmeasured anions than unmeasured cations. And the anion gap is the difference between the two. So unmeasured anions minus your unmeasured cations will give you your anion gap. Now if you take your major cation, sodium, and add the unmeasured cations, it should be equal to your chloride and bicarbonate, which are your two major anions, plus the other unmeasured anions. If it's electrically neutral serum, those two sides should equal each other. Now if you do some rearranging and you subtract the sum of the chloride and the bicarbonate from sodium, that's going to equal your unmeasured anions minus your unmeasured cations, which is your anion gap. So this is how we calculate the anion gap. We take your sodium and we subtract the sum of chloride plus bicarbonate. And a normal anion gap is going to be less than 14. Now usually I use 12 for this just because it makes some of the math easier, but 14 is a normal anion gap. So this graphic is showing on the far left the anion gap, and so anion gap is the little red block, so you have your sodium should be equal to the chloride plus the bicarbonate plus your normal anion gap. Now if you have extra acids in the blood, that will make the anion gap go up, and so you'll see in the center where it says HAGMA, that stands for high anion gap metabolic acidosis. Your bicarbonate has gone down to buffer the excess acids, but your anion gap has gotten bigger. But all of those combined with chloride should still equal your sodium. So if we go back to our 12-year-old boy in the emergency department with lethargy and we get some additional labs, now we can calculate his anion gap. So if the anion gap is the sodium minus the sum of chloride and bicarb, we have 140 minus 100 plus 5 is going to give us an anion gap of 35. And remember that a normal anion gap is less than 14, so this boy has a very high anion gap. Now, the most common mnemonic or acronym that you can use to remember the causes of elevated anion gap metabolic acidosis is mud piles. So the M stands for methanol, which is a toxic alcohol. U stands for uremia. So in end-stage renal disease or acute renal failure, you have buildup of different organic acids, and that can cause an elevation in your anion gap. Diabetic ketoacidosis leads to production of keto acids, which will elevate your anion gap. The P is for paraldehyde, which is a drug that's not really used anymore, but you may see propylene glycol, which is another alcohol that elevates the anion gap, and paracetamol, which is another name for Tylenol, in overdose can cause an anion gap metabolic acidosis. The I is for iron and isoniazid. L is for lactic acidosis, which is one of the more common clinical anion gap metabolic acidoses you'll actually see. And then E is for ethylene glycol, which is another toxic alcohol found in antifreeze. And ethanol can cause keto acid production. And the S is for salicylate overdose or aspirin overdose. And also starvation can cause keto acids. Now, if you look in first aid, they actually use a different mnemonic for anion gap metabolic acidosis. They're using Goldmark. I don't actually know anyone who uses Goldmark. I'm sure it's fine. Most people use mud piles. You can decide which one you want to use. All right, now we have a 40-year-old woman coming to the emergency department with profuse watery diarrhea for the last 5 days after going to Laguna Beach Water Park, and her chemistry and blood gas are shown below. So her pH is less than 7.35, so we'd say she has an acidemia. So there must be a respiratory or metabolic acidosis. So we look at the PCO2, which is lower than normal, so that would not explain her pH. We look at the bicarbonate, which is lower than normal, and that would be consistent with a metabolic acidosis. Next, we calculate her anion gap, so 145 minus the sum of the chloride and the bicarbonate, 120 plus 16, and we get an anion gap of 9. So this would put us over on the right side where we have a normal anion gap, where the anion gap is the same as regular, less than 14. We still have a decrease in bicarbonate, and so we see an increase in the chloride. So normal anion gap metabolic acidosis is sometimes called hyperchloremic metabolic acidosis because the chloride will go up to maintain electrical neutrality. The most common causes of normal anion gap metabolic acidosis are going to be related to a loss of bicarbonate either in the stool or in the urine. So if you have really severe diarrhea, you can lose bicarbonate in the stool. And then if you have like a type 2 renal tubular acidosis, then you're not going to reabsorb bicarbonate at the proximal tubule. Also, if the kidneys are unable to excrete acid, like in a type 1 or a type 4 renal tubular acidosis, that will cause a normal anion gap metabolic acidosis. And here's a helpful mnemonic that I will not say out loud that can help you remember the causes of normal anion gap metabolic acidosis. So H is for hyperalimentation, which means basically too much nutrition, and this is something you can see in patients who are on total parenteral nutrition, where they're getting all of their nutrition through an IV. A is for acetazolamide, which is a carbonic anhydrase inhibitor, so it's going to prevent the reabsorption of bicarbonate at the proximal tubule. R is for any of the renal tubular acidoses. D is for diarrhea, which is probably the most common thing you'll see clinically. And then A is for adrenal insufficiency. So remember, when you have hypoaldosteronism, that can lead to a type 4 RTA and failure to excrete ammonium, and that's also going to be the mechanism for spironolactone. And then the last S is for saline, which is referring to normal saline or isotonic saline that you might give someone a bag of fluid in the emergency department or the hospital that has a lot of chloride in it, and so that can actually lead to a normal anion gap metabolic acidosis. Okay, so back to our patient. The next question is, does she have appropriate respiratory compensation? And so remember, we can use Winter's formula to calculate that. So we take 1.5 times her bicarbonate, which is 16, and we add 8, and we get 32. And her PCO2 is 33, so pretty close, and I would say good enough for government work. I think that she has appropriate respiratory compensation. All right, next case is a 4-month-old baby with a pyloric stenosis who is admitted with intractable nausea and vomiting, and their blood chemistry and gas are shown below. So the pH is more than 7.45, so there is an alkalemia. So there must be a respiratory or metabolic alkalosis. So we look at the PCO2 first, and we would expect the PCO2 to be low if that was the cause of the alkalosis, and the PCO2 is actually higher than normal. And we look at the bicarbonate, and it is high, which does explain or could be consistent with a metabolic alkalosis. Now, this particular case also has low potassium and low chloride, which are consistent with someone who's been vomiting for a while. So if you've been throwing up, you're throwing up hydrochloric acid, your chloride is going to go down. You're going to get activation of RAS, which is going to lead to upregulation of aldosterone, and so you're also going to be losing potassium. And so the classic exam question for someone who's been vomiting is they're going to have a hypokalemic, hypochloremic metabolic alkalosis. And if you see this in a baby, then the answer is almost always pyloric stenosis. So remember, pyloric stenosis causes vomiting, which leads to a hypokalemic, hypochloremic metabolic alkalosis. So metabolic alkalosis is often caused by a loss of acid from the GI tract, either from vomiting or suctioning, like if you put a nasogastric tube into someone with a bowel obstruction to decompress them and you're sucking out all of the acid, they will get a metabolic alkalosis. It can also be from exogenous bicarbonate, so patients who have been taking way too many Tums will develop a metabolic alkalosis. And then also anything that causes an excess in aldosterone activity, that's going to stimulate proton secretion by type A intercalated cells and generate new bicarbonate, which will increase your pH. And then there's also something called a contraction alkalosis. So in patients who are hypovolemic, their extracellular volume gets contracted, and they're going to have an increase in sodium reabsorption at the proximal tubule, and that is coupled to hydrogen secretion. They're also going to have activation of RAS, which will increase aldosterone, which will increase proton secretion by type A intercalated cells and generation of bicarbonate. And so you can see this contraction alkalosis in anyone who is hypovolemic, but the classic causes are going to be someone who's been taking a diuretic. So loop diuretics and thiazide diuretics can both cause a contraction alkalosis. And there's some other conditions like Barter's and Gittleman syndrome where they have a mutation in the NKCC2 for Barter's and the NCC transporter for Gittleman syndrome, and that will lead to them developing a contraction alkalosis. So how does the body respond to metabolic alkalosis? Well, just like with metabolic acidosis, there's going to be respiratory compensation. In this case, the increase in the pH will be detected by the brainstem and lead to hypoventilation. So slower and more shallow breathing to retain carbon dioxide so that you can try to get your pH closer to normal. So you'd expect that the PCO2 will increase by 0.7 for each 1 milliequivalent rise in bicarbonate above normal. So for our patient here, do they have appropriate respiratory compensation? So we say normal bicarbonate is 24, so we subtract that from 34 and we get 10. We multiply by 0.7 millimeters of mercury, and you'd expect that the PCO2 will go up by 7 millimeters of mercury, which it does in this patient. So this is consistent with a metabolic alkalosis with appropriate respiratory compensation. All right, now we have a 40-year-old who was brought into the emergency department by ambulance, and their blood gas and chemistry are shown below. So first we look at the pH, which is less than 7.35, barely. So they have an acidemia. And we look at the PCO2 in the bicarb, and the bicarbonate is low, so that is consistent with a metabolic acidosis. The next step is to calculate the anion gap. So we take 140, subtract the sum of the chloride and the bicarbonate, 114, and we get 26. So that is higher than 14, so this patient has an anion gap metabolic acidosis. So then we ask, is there respiratory compensation? So we use Winter's formula. and we plug in the bicarbonate, which is 14. We get 1.5 times 14 plus 8 equals 29. But we see that on the blood gas, the PCO2 is actually 24, which is lower than expected. So that means that there is also a respiratory alkalosis present. And this can be consistent with a salicylate overdose. So because salicylates will uncouple oxidative phosphorylation, you'll get a lot of organic acids like ketones and lactate, which will cause an elevated anion gap. You also get stimulation of the respiratory drive directly by the salicylates, so that can cause hyperventilation and a respiratory alkalosis. And so the pH could be either acidemic or alkalemic depending on which disturbance is worse. So sometimes you'll have a patient with a pretty normal looking pH, but if you actually look at the numbers, you can find that they have some kind of mixed acid-base disturbance. So in a mixed acid-base disturbance, often the pH is close to normal. So in our patient, it was like 7.34. But if you calculate an anion gap in every patient, then you won't miss if there's an anion gap metabolic acidosis, because if the anion gap is over 14, then there is an anion gap metabolic acidosis, even if that patient's pH is over 7.4. And this is why you want to do your calculations for compensation, because if the numbers don't add up, then there's probably something else going on as well. So for a patient who has a metabolic acidosis and their PCO2 is higher than you'd expect, then there could be an additional respiratory acidosis. And likewise, like for our patient, if you have a metabolic acidosis and the PCO2 is lower than expected, there could be an additional respiratory alkalosis. Now you can also have an anion gap metabolic acidosis with a normal anion gap metabolic acidosis, or you could have an anion gap metabolic acidosis with a metabolic alkalosis. And there are some different tricks and formulas for figuring that out, but that is beyond the scope of this module. All right, so these are our learning objectives. We talked about the 4 most common acid-base disorders and how to interpret a blood gas, how to calculate an anion gap. We've talked about the different causes of anion gap and normal anion gap metabolic acidosis, and we've looked at ways to predict how the lungs and kidneys will compensate. All right, thanks for your attention.